Good morning, everybody. Good morning, everybody, and welcome to our first Roy Castle Lung Cancer Foundation alumni meeting. For those who don't know, I'm Jesme Fox. I'm the Foundation's Medical Director, and it's great to welcome you all here. This was an idea that we had some time ago to bring all the clinical and research experts that we have who advise us at the Foundation and also our grant holders together for a meeting. And then we thought, well, what would be useful? And hence we came to this idea of an educational session and then to an ASCO update. Before we get into that, I have a few housekeeping rules which I'm advised I have to. Could you please turn your mobile phones off? This session is going to be filmed, as you probably have noticed, and it would be great if you turn your mobile phones off. Obviously, we're in the Wellcome Foundation today, and we're told there is no fire drill anticipated, so if the fire alarm does go off, we will be escorted out by a fire marshal, and the fire doors are to the right and the left on the way out. The restrooms, if you need to know, are on the left on the way out of the door. So this morning's session is an update, a lung cancer update from the ASCO meeting, which has taken place earlier on this week. And we're doing this in partnership with the British Thoracic Oncology Group, who have provided all the clinical expertise required for this update. So a very big thank you to BTOG and to Sanjay Popat and the team from BTOG. Also a very big thank you to Sue Mayer, our health writer, who's been in America coordinating all of this. So without any further ado, I'm going to hand over to Dr. Sanjay Popat, who's president of BTOG, who's going to chair this part of the session. Thank you.
So Jesme, thanks very much for that excellent introduction. So I'm delighted to be co-hosting this first ASCO update meeting, really where we've got everybody in the room, and those of you that are looking at this on the web can appreciate the nature of the data that's been presented in the US just over the weekend. So those of you will have attended ASCO will know that it is the international meeting for the oncology multidisciplinary community. It's attended by up to 30,000 people with all folks of representation from the oncology MDT internationally attending. And it is absolutely the place where the most groundbreaking, practice-changing data is presented. And I'm delighted that we'll have some of this here presented today, and we'll be able to discuss with our faculty how this might be implemented in our routine practice and what research opportunities this also brings to us as well. So as I mentioned, the ASCO annual meeting occurred between the 3rd and 7th of June in Chicago, and there have been quite a few data presentations made there which I think will influence how we approach our patients with potential diagnosis of thoracic malignancy, change our thoughts on the diagnostic paradigm, and also some new data to support new emerging treatments and potentially consolidate treatments that we've already established in our centres. We've got an excellent faculty presenting today, 3 members of the BTOG community who support BTOG a lot. That's Dr. Richard Booton, Dr. Fiona McDonald, and Dr. Tim Benapole, and they'll be giving us a presentation overviewing the latest data just over the weekend, and we'll have an opportunity at the end of their presentation to ask them questions about that. So without any further delay, I'd like to introduce our first speaker. That is Dr. Richard Booton. Many of you will know Richard. He's a member of the BTOG steering committee and is a consultant chest physician at the University Hospital of South Manchester. He also has an international hat on, which is that of the Regent for the UK for the International Association for the Study of Lung Cancer, ISLC. And Richard's going to be speaking to us about the diagnostic staging and screening paradigm, the new data here, and I very much look forward to hearing what you have to say, Richard. Thank you.
Thank you very much, Sanjay. Thank you to Jesme and the Roy Castle for putting this session on, and I'm delighted you've all made it. So I've got the challenge of telling you about diagnostic staging and screening, and I've added a bit of a broader sweep to this as a chest physician, so it's not entirely about that. And obviously at ASCO this year particularly, perhaps not a massive amount of new data in these fields, but I'm going to recap a little bit about screening and talk through some of the things I found very interesting as the lead clinician. These are the sort of topics I'm going to cover. Screening, there's a little bit of smoking cessation stuff I just wanted to highlight. There's a reasonable amount on post-treatment surveillance, a couple of posters on quality of care, I think some very significant things on treatment delay, first time I've seen data of this ilk. And then if we have time, I'll just talk a little bit about the respiratory side effects of immunotherapy, which of course is likely to be challenging for us as chest physicians going forwards, and there was a poster on patterns of disease there, which I said might be very relevant. So in screening terms, Denise Aberley, who was one of the lead investigators for the National Lung Screening Trial, presented a nice overview. And for those of you who are not aware, although I hope you are, this is the baseline data. A few years ago now, we essentially recognised that low-dose CT scanning could contribute to 20% mortality reduction in current or former smokers within 15 years of quitting if they had an annual low-dose CT scan. The difficulty with CT is that you do get a false positive rate, around about 25%, but significantly in that trial at least, there were very few complications from investigations of those false positives. You can see less than 0.1%, which is obviously very good. And the number needed to screen was, to prevent one death was 320, and that compares very favourably with established screening programmes. And there's this perpetual problem of overdiagnosis, although I think probably not something I'm too concerned about myself. Now, since that publication, there have been a number of organisations who've fiddled with the data a little and extended the indications for screening. So the NLST cohort is this, and the US Preventative Task Force broadened that on a basis of modelling to an upper age limit of 80 years. This is the US Medicare scheme, which very much tries to mirror these. But what was new to me, and I'm glad talking to some colleagues this morning, new to them too, that passed me by, was that there was a category 2 for the NCCN guidelines. You can see these differ quite considerably. They've dropped the lower age range, they've reduced the minimum smoking intensity, and there was no maximum quit time. But in order to be a category 2 screenee, you do need to have an additional risk factor, and this includes family history of lung cancer, personal cancer history that should be lymphoma, lung cancer, head and neck cancer, or other smoking-related ones, airways disease, pulmonary fibrosis, a recognised clinical risk factor for lung cancer, and other pulmonary carcinogens listed in the bottom here, most notably asbestos. And the reason for presenting this will become apparent as I go through. This was some data published a year or two ago that had included category 2 criteria. And you can see the bottom line is this, that the incidence of lung cancer detection was very similar to the NLST cohort. So a useful extension to our screening criteria. But is age and smoking history sufficient? And I think what this paper from Chris Berg, another NLST investigator, demonstrated was that if you just use age and smoking, even in the variables that were suggested, you only really cover about 30% of lung cancers, and perhaps only about 10% of the population as a whole. So it's not perhaps considered the best way of picking your screen participants. Now it just dawned on me this morning, possibly because of jet lag, that I shouldn't really talk at a Roy Castle meeting about risk prediction models for lung cancer without mentioning the LLP model. But I don't have a slide because it wasn't discussed at ASCO. But this is one of the American risk models. This is the PLCO model, or what's become known as no, it is the PLCO model, I'll stick with that. And as you can see, this has been well validated based on the prostate, lung, colon, ovary trial, which was a very large chest X-ray screening trial in the US. and has then been externally validated on the NLST data. And it incorporates a lot more risk variables that, again, we all recognise as being relevant as risks of lung cancer. And this, if you apply this rather than the preventative task force criteria, you can reduce the number of screenees by 10%, but still get around about 10% more lung cancers detected. So it's a much more cost-effective way of doing things. And again, because it utilises this set of variables. And that's if you set it at a risk of 1.5% over 6 years. The problem we have, though, is when we do these screens is we find lots of little nodules, and nodules defined as a solid thing that's less than 3 centimetres. This doesn't display brilliantly, but just focus on this side. This is the baseline screen. Nodules 4 to 6 millimetres, and actually year 1 and year 2, it's about the same. About 50% of patients will have one of these nodules. But if you look at the next column to these, very few of those will turn out to be a malignant nodule. They'll be inflammatory or infective. And so broadly, this idea that we use size to manage nodules is perhaps, on its own, is perhaps fading into the distance a little. And so again, there are other things that we can look at apart from size alone, and that's what it looks like. Is it solid? Is it quite a faint-looking nodule, what we call ground glass? Does it have very spiky margins or spiculation? And is it predominantly in the upper lobe, which is where most lung cancers tend to occur? So if you look at these things, you can again produce risk prediction models. The American College of Radiology have produced lung RADs, and they use this based on character and size to determine the follow-up protocol. But the Americans also used a risk prediction model which they developed and validated with really incredible statistics. I'm no statistician, but these AUCs for these things are very, very good indeed. And of course, this was the truth here was based on formal histology or very benign 2-year follow-up. And so those risk prediction models are being used clinically now. They've certainly been integrated into the BTS nodule guidance published last year. Dr. Aberley suggested that success would be defined by inclusion into point of care practice, and I think we're doing that already, so those risk prediction models are really very useful. But screening's here, and I think, and it's here to stay. In the UK, we're a little behind the Americans, but there are lots of trials happening around the country, many of which are incorporating these risk prediction models. So why am I talking about all that? So there are 3 posters I wanted to highlight. One was this, which was a biobank study of serum that had been archived away and from patients who then subsequently developed lung cancer. So you can see here that these were blood samples perhaps 1 to 4 years before diagnosis. And they looked at microRNA profiles. Now, this is probably the most promising biomarker, I would say, in terms of this particular use. They tend to have a signature that's very particular for the organ of origin as well as the disease. And they were able to detect these microRNA species in the blood up to 1 to 4 years prior to the diagnosis of lung cancer. Now, whether doing a blood test in addition to these risk prediction models will be something that's useful going forward is difficult to know. Clearly adds to the expense of what we can get fairly easily from clinical histories and CT scans. But I think it's interesting that lung cancers we know take a little while to develop, but there certainly appears to be a signature that allows us to perhaps pick up, and maybe in something like non-smoking lung cancer, something like this would enrich the population a little and make it more viable. But we certainly don't screen for non-smoking lung cancer at the moment. This was a community-based project of low-dose CT screening, and I think the importance of this is that most of the lung cancer screening studies you'll read about have been exactly that. They've been research protocols. They've been an invitation to participate with a consent process, etc., etc. Introducing screening in the community is different. It's your GP is recommending you go, and so in a way, I think I've highlighted that here. So there was a primary care referral to a program. They used category 1 and 2 criteria, which is the significant thing. And I think they've, you can see here that we're, obviously the majority were category 1, about 25% were category 2, age range as you'd expect from the selection criteria. So they stuck to the criteria very rigidly. They were still able to demonstrate perhaps, I don't know, 75% or so of stage 1 disease, so a really significant stage shift, which is obviously what we want to see. And that most of these tended to be early stage cancers. Yeah. So that's, you can see, for a community-based program, perhaps with a real life tinge, without the rigor of clinical trial, to still see this very significant shift above what the NLST saw is quite encouraging. This surprised me a little. This is an Italian study, but where they were following asbestos exposed subjects. Right, so very much category 2. These weren't, the smoking histories in these people were not at all of the ilk that you would expect to get into screening. I'll skip that. I blew that up so I could try and understand how they got to their numbers. It does add up in the poster. But the bottom line is this, that for both all-cause mortality and for lung cancer, they were able to demonstrate a reduced lung cancer mortality, as we expected from the literature. But that's purely in asbestos-exposed individuals followed over time. Interestingly, cancer of the pleura, or mesothelioma, didn't demonstrate any such association, which of course is not surprising given that it's very difficult to cure that disease. So that's it for screening. Smoking cessation, again, nothing much new on this, just to say that, just to highlight that this, if you just come back from Chicago, you perhaps don't need a 100-page document of turgid smoking data to get you off to sleep. But the summary of this 2014 Surgeon General's report was quite interesting in the sense that we know smoking causes adverse health outcomes, it increases your risk of mortality, both all-cause and cancer-specific, and it increases your risk of second primary cancers. But I think for the first time, there was a very strong statement that there is suggestive evidence, though not yet causal, that cigarette smoking increases your risk of recurrence, poor response to treatment, and increased treatment-related toxicity. Now, I think we have some idea about that in radiotherapy terms, but I won't try and touch on that. But this is about all forms of treatment. Okay, surgery, chemotherapy, and radiotherapy. One of the guys the chap that was presented this, a chap called Graham Warren, and I've heard him speak a number of times, and very enthusiastic advocate for smoking cessation. In his institution, they have this automatic referral to screening for smoking cessation. You get referred in to see the doctor, you absolutely will see somebody about your smoking. And the interesting thing about that is that, you know, they contacted a large number of people, but in terms of the people that refused to participate was very small, 3%. Whereas if you were just left to ring somebody, you should speak to so-and-so, they had about 1% of people taking up that offer. So this motivation to just make you go and see a smoking cessation counsellor obviously had good effects. And when they look back at their program, I'm not sure if this displays very well, over a 2-year period, they demonstrated that if you continued to smoke, your mortality, your hazard ratio for death, was 80% higher than those that quit at the time of diagnosis. Now, they weren't inferring at all at this point that this was causal, but it's interesting data, I think, that just reinforces what was said in the Surgeon General's report. He also talked about oncologists' commitment to smoking cessation and who should do it, and the literature certainly suggests that oncologists believe anybody but them. And to some extent I have a similar thought process, but it's to reinforce we should try and maximise smoking quit rates, not only for those having palliative treatment, but certainly for those having curative ones. So surveillance, there are two or three things here to highlight. Well, this was the first two are in stage 3 disease after chemotherapy or concurrent sequential chemoradiotherapy. This was a smallish study of about 311 patients. And they were asking the question really, is routine CT or symptom-driven surveillance the best thing to do? It's retrospective data, and they didn't really show any difference such that they felt that symptom-driven detection was fine. I'll spend a bit more time on this one, which is a much larger study. Where's the numbers on this? I haven't memorised them, I'm afraid. Here we go, 15,000 stage 3 non-small cell lung cancers who received treatment with curative intent of about 2,400. And these guys were followed with CT, and they demonstrated a healthy improvement in survival over, I think, a 5-year period. So contradictory to the previous poster, but certainly a bigger study and it seems intuitive to me that if you're looking before symptoms, you would expect to be able to create a survival benefit. This was a late-breaking abstract at ASCO. This was about a web-based application to monitor your patients post-treatment. And this was predominantly chemotherapy and radiotherapy. In small cell and non-small cell, patients had to have internet access, had to be good performance status, they could be on maintenance therapies, and this was their algorithm. So they randomized people to the web application, and a slightly different follow-up protocol for early and late stage disease, but nonetheless quite hands-off as a planned evaluation. And then in the control arm, their standard follow-up process for stage 2 and 3 disease, probably 6 monthly CT scans. And then for 3B and 4, which is perhaps slightly more curious, is that every 3 months they scanned. And their endpoint was overall survival. Now this phase 3 randomized study was closed early because of this. They detected an overall survival gain at 1 year of about 26% for the web-based application. Now what this was patients on a weekly basis feeding in their symptoms and how they felt and such like into a web-based portal. And it then made some analysis of their symptoms and decided whether you were going to get brought up and scanned or seen a doctor or left alone. Median survival, I think most of the oncologists would be pretty envious of this. For simple web-based, I find it almost difficult to believe myself, but it's there nonetheless. 3 times less death. And much of the benefit was felt to be that because at relapse, patients were of a much better performance status and had a much higher rate of optimal therapy for that progression. It also picked up some other dangerous medical conditions like pulmonary emboli and such like, and with less imaging. Not surprisingly, the questions were about when is this available to buy, and 2017 is the answer. Quality of care. Now this is always something I like to look at and made a career out of publishing in regards to endobronchial ultrasound. This first poster was really about trying to find a quality metric in surgery. So what these guys did, I'll try and blow this up for you. So again, this was 100,000 patients with stage 1 to 3 disease who underwent surgery, and they produced a model to estimate the expected number of resection margin positive cases in each facility, and these are in over 800 facilities around the US, and calculated the observed and expected ratios. And they labelled institutions as outperformers, as in better performers, or underperformers. And the bottom line was that there was I think a 4.5% observed rate of margin positivity, but that varied 8-fold. And that's significant. Margin positive is important because if you've got positive margins, you definitely have worse survival. And in the overperforming institutions, they demonstrated a 5-year all-cause hazard ratio, I think about 0.88. And I think, if I can just blow, and again, the 5-year survival for lung cancer was significantly better in the outperforming institutions. So they appear to have come across a quality metric that might be transferable into sort of everyday monitoring practice. And that's what they've certainly suggested, that You know, I think anything that's practical, anything that relays a little bit on your manual skills, you know, we should be monitoring this a lot more effectively than we do in routine practice. This was about mediastinoscopy. This won't surprise a lot of you. Again, good number of patients, just under 2,500, but very few actually got mediastinoscopy in this series, only about 14%. And in the patients who did not get a mediastinoscopy, there were good reasons why they should have had. So the patient selection for mediastinoscopy was really poor. So a third had big tumours, 15% or so had nodal disease, and some had pet hot nodes. But if you did get a mediastinoscopy, the quality of that mediastinoscopy was also really poor, in that in those patients who had mediastinoscopy before surgery, after surgery, they were found to have N2 positive nodes, which is the thing you're trying to avoid operating on. Okay? And that they also demonstrated there was a significant difference in the sampling of nodes at surgery versus mediastinoscopy and surgery. There shouldn't really be a difference. If you're doing surgery, you should have the same number of nodes taken out as if you'd done mediastinoscopy and surgery. But there was far less in the surgical group as a total, 8 versus 13. But they spotted this for all groups, whether it was the number of N1 nodes, the number of N2, the number of N2 stations, and totally. So this is a really sort of in-depth analysis of surgical practice, whether that's because in the US they don't have the same stuff that we have in the UK in terms of dedicated thoracic surgeons doing this work. It might be general surgeon, cardiothoracic surgeon. That's not really explored in the abstract, but I do think, having looked at this type of data in our own institution, that there's been a big shift in, if you don't measure this, you'll find that you're seeing quite a lot of poor practice. And then just to carry on with that theme a little, that this was from the same authors actually, this chap here, I'm not going to try and suggest what his name is there, Raymond we'll call him. So this was about pathological nodal staging practice in the US again. This is 125,000 patients. This is no lymph node examination, not number, right? So this is no lymph nodes were examined, and these are institutions that range from community practice to National Cancer Institute programs. So in a way, I think this is supposed to be the exemplar that only 4% of these operations in these institutions had no lymph nodes examined at operation, but again with a twofold variation at least. And Peter Goldstraw will tell you that you should just sample as many nodes as you can. So here they've said 10 plus lymph nodes examined, and in these perhaps the highest performing institutions, 51%, but again, twofold variation. And it's not surprising, therefore, if you're taking out a lot of nodes and not submitting many without nodes, that you'll find that the conversion from clinical N0 or N1 disease to N2 or N3 is much higher. Now, when I first looked at this very quickly, I thought, well, hang on, these aren't very good, are they? Because they're converting a lot of people to... But you can understand the rationale that if they're not submitting nodes, then you're not going to find the conversion. So, bottom line is that, again, there is a survival difference. And it doesn't make a great deal... It makes a great deal of sense, doesn't it? If you leave nodes behind that are involved, you are going to see that that translates into quite a significant survival difference at 5 years. Time to treatment. Now, I like these two posters because with the new staging manual coming online in January next year, which argues for approximately 1 centimetre of tumour growth means a 10% reduction in survival at 5 years. You tend to imagine that the more we delay, we're going to start seeing adverse, actually. With better staging, you'll see more adverse outcome. And these two posters are the first recognition of that, I think. Oops, did I just press that twice? Let me just go back. So, just wanted the numbers. Here you go. So there's a total of 700,000 adults with non-small cell lung cancer. Okay, so a big study. I've just blown this up for you. In stage 1 to 2 disease, and here at the side, operated on immediately within 4 weeks, 4 to 6 weeks, and greater than 6 weeks. As you move across here from 12 months survival, 12 to 36 months, and then beyond 36, you can just see here, this starts to suggest that there is a survival difference coming out here, and certainly at year 3 and beyond, you're seeing a significant difference in longer-term survival just for that delay to 4 weeks and 6 weeks after the diagnosis of lung cancer is made. In stage 3, a similar trend was seen, but not in stage 4. And these are very clearly separate Kaplan-Meier curves. This particular, I don't have the graphics for this, I'm afraid, but this was a merit award at ASCO. Not quite as big as the previous study, but certainly 10,000 patients in this. And they said the median time to surgery in this cohort was 37 days. And that's probably similar, isn't it, to the UK? It feels it takes 3-5 weeks to get to surgery. And about 61% of patients had their surgery after 30 days. Beyond 37 days, the increased risk of death was significant. And then beyond 40 days, higher still. Okay, 11 and 16% higher than you'd expect. So for the first time, I think, ever, there's pretty compelling data that what we often tell patients in the curative setting, that actually it probably doesn't matter 2 or 3 weeks, 4 weeks, I think clearly does. And then lastly, side effects of immunotherapy. There are 2 or 3 other chest physicians in the audience, so this is going to impact on us. This is about pneumonitis in immunotherapy. So basically we're turning on the immune system and then the lungs are going to get some sort of reaction. This was a series of patients treated in a single institution, and they've just really highlighted what patterns they were seeing. And I think from my perspective, these tend to be 75-year-olds. Well, I suppose they fit the lung cancer demographic. Included some never smokers. All were Caucasian. Median onset of option from immunotherapy was about 2.5 months. All resolved with steroids. But when they were re-challenged, after steroid taper, some others got further bouts of pneumonitis. The interesting thing from a diagnostic perspective is that the pattern here often looked like quite solid disease on a CT scan, sort of organising pneumonia. Some were ground glass in appearance, and some had a very nodular appearance. In those that were sampled by bronchoscopy, mainly lymphocytic infiltration, perhaps not surprisingly given the nature of how these drugs work. But we did see granulomatous inflammation and some eosinophilic inflammation, which I think is important for us to just recognise as we sit and look at our results. So this, I'm sure, in the next year or two is going to, assuming we actually start prescribing anything, will start to impact on our practice. But largely that's all I have to say. So thank you very much for listening.
Richard, thank you very much for that excellent presentation. I'd like to open this to the floor for questions. Do any of you have any questions for Richard about the data that's been presented? We've got a few minutes to pick Richard's brain. If there are any questions, put your hand up and the microphone will be given to you. I'll ask one question to Richard. Was there any data on e-cigarettes presented in the meeting? Any updated data on toxicities or any benefits from e-cigarettes compared to conventional tobacco products?
No, didn't see anything at all in the dedicated sessions or indeed from any of the other sort of quality and pathway stuff. Didn't see anything at all. And I don't think, just as an aside, I don't think I've seen a great deal in general that's come out.
Brilliant. So perhaps that might come in future years. A question, the microphone please to Neil.
Thank you, Richard. That was a very helpful presentation. I was particularly interested in the web app data, and I got a flurry of messages from Chicago saying, what is in this app? Why is it working? And was there something wrong with the control arm that meant there was such an enormous benefit to using it?
Well, not that was highlighted in the... So to answer the last part first, not that was highlighted in the presentation, and certainly not from the available literature that we were given. There was very little detail given about what the web app was, just that patients had it and could, feed in how they felt, and that it was then handled by the application as to whether the physician got an alert or were reassured.
But did it clarify what sort of medical interventions occurred subsequently that might have resulted in a survival benefit?
So they did, I think the poster specified that they basically had a physician's assessment and then would have imaging depending on that assessment. The planned interventions also seem to have a fairly structured setup to them as well, in terms of if you came to clinic for those structured interventions that you had certain things done, but again there was no real expansion of what those interventions were. But it's tantalising to some extent. But I guess the question is, isn't it, that is it picking up radically treatable recurrence or just allowing you to start your chemotherapy early? Is something that will need to be teased out, I suppose.
Can I also pick you up about the survival advantage that was noted by treating patients in a timely fashion early on in their pathway? So I think the data that you presented was absolutely fascinating, and it sort of highlights the importance of having rapid diagnostic pathways right at the beginning of when we see the patients. And as you know, we conducted a randomised trial that suggested just a 2-week shortening of that pathway can have a significant survival advantage subsequently. I was surprised to see that was reproduced in the US healthcare system as well. And do you think there was anything in particular that they felt could have been shortened in terms of their pathway to
Well, of course, that's a retrospective trial. It wasn't a prospective thing, and so they're looking at people who just happen to have their surgery at various time points, and that's the signal they've got. So I think, for me, the point of presenting it is to reinforce that fact that actually the tolerance of delay that we seem to have in the NHS, we really have to be quite aggressive at saying this is just not acceptable. That it's not 31 days or 28, if that's the new black or whatever, is 3. Oh, come on. I mean, as clinicians, we know it doesn't make any sense at all. And if you're a patient, I'm sure you want to know that tomorrow's slow enough. So no specific answer to it, but I think it's quite nice to see some data that you can reference and try and persuade people that it's time for a really significant change.
Thank you. And one final question, David. You had a question here in the front row.
Thank you. Richard, I was interested to hear about the compulsory smoking cessation advice and that there was a very low refusal rate. And to me it seems that might be, if we can use that and implement that here, is actually quite a quick fix and something that is actually very doable. But as you say, maybe everybody thinks it's everybody else's responsibility. Certainly, I would agree that perhaps we don't, as oncologists, focus in on, I suppose, and interesting to hear from the nurse view, but we maybe delegate that to certainly in our joint clinic to the specialist nurses.
Yeah, and I'd agree. I think we're certainly no different as a group of doctors that we will refer to the Smoking Cessation Council. I think the biggest role we probably have as a group of physicians is to make sure that there is actually a smoking cessation counsellor. I mean, in Manchester now, I think we're the only hospital in 10 that has smoking cessation counsellors, because they've all been withdrawn by City Council and it's up to GPs to decide whether they want to provide it now. So this sort of stuff is really disappearing off the agenda, and we have to fight to have it back. It clearly seems a very straightforward thing to put in place.
Great, thank you very much, Richard. I'd like to thank you very much for putting that data together. Thank you. I'm delighted to invite our next speaker here for the next presentation. Our next speaker is Dr. Fiona McDonald. Fiona is a clinical oncologist at the Royal Marsden Hospital, and many will know her because she's has expertise in the delivery of radiation oncology. She's a great supporter of BTOG, and it gives me great pleasure to introduce Fiona here to give us an update on what I think is the most interesting section of data that was presented at ASCO this year, which is about radiotherapy, radical and palliative treatments. Fiona, over to you.
Thank you very much, Sanjay. So thank you for inviting me here to talk today, and I'm hopefully just going to give you a whistle-stop tour of everything interesting, which is all things radiotherapy at Chicago this last week. So just as a bit of an overview, I'm first going to talk about localised small cell lung cancer and our UK CONVERT trial, and then go through some data in resectable non-small cell lung cancer, locally advanced non-small cell lung cancer, and then synchronous oligometastatic non-small cell lung cancer. So first of all, the highlight for me was going to see the CONVERT trial presented. This is a CRUK funded international phase 3 study led by Professor Favrafin of the Christie. And many of you in the room will have contributed to putting patients in this study. So the background is, although there's a small proportion of small cell lung cancer patients, until recently we haven't had a defined standard of care. So the best data we have in the concomitant chemorad setting comes from the Teresi paper published back in 1999, which introduced twice-a-day radiotherapy as showing the best results we've had in this disease setting, with a median survival of 23 months. However, this hasn't been taken up terribly widely, and data in the States suggested in 2006-2007 only 21% of patients were treated with this. Now, this is partly due to a perceived increase in toxicity, and partly due to the resources. So it's quite resource intense to be able to deliver twice daily radiotherapy, similar to the problem we've seen with the update potentially of CHART, which was 3 times a day radiotherapy. And then there was a lack of consensus if you're doing once a day radiotherapy as to what that regime should be. So the inclusion criteria in this trial are fairly standard. The only thing I want to highlight here, different to the Teresi paper, is that the adverse biochemical factors for small cell patients of serum alk-phos, serum sodium and serum LDH, the maximum of one of those adverse features to go into the trial. So the study design, patients were randomised to either having twice-a-day radiotherapy over 19 days to a total dose of 45 Gray and 30 fractions, compared to a once-a-day dose higher than we would normally have given in small cell lung cancer, 66 Gray, 33 fractions daily, ideally with over a maximum of 45 days. And those that had at least stable disease afterwards also went on to receive PCI. There was no upper age limit in this study, and the stratification factors were centre, number of cycles of chemo 4 versus 6, and performance status. The primary endpoint was overall survival, and it was powered to look for a difference and benefit in the once daily arm of 12% at 2 years, with a number of fairly standard secondary endpoints. Patient characteristics were well balanced. I won't go through them all, but just to highlight, despite the fact they were well balanced, again, different to Teresi, we see that in this modern era, a large percentage of patients were PET stage, nearly 60% in both arms. So when it comes to the chemotherapy, what was planned, number of cycles planned and delivered, again, well balanced between both arms. And radiotherapy, again, planned and delivered, well balanced between both arms. So the full dose was delivered except for the full dose delivery. So if you imagine 45 Gray, it's much easier to meet your dose constraints than giving the higher dose. So we do see that a smaller proportion of the once daily patients were able to be planned to the maximum dose. The optimal number of fractions was similar in both arms, and more patients we were able to deliver the BD dose over 3 weeks in the time frame of the 19 days as opposed to the extended course, because you clearly have a greater chance of bumping into more bank holidays and etc. And it's not always easy to start radiotherapy on a Monday. So overall survival, so it was powered for overall survival, so it was statistically, the primary endpoint, it was a negative study in the sense that there wasn't an overall, a statistically significant overall survival benefit, despite this trend seen for improved survival in the BD arm. However, interestingly, you can see over here that the projected survival in the once daily arm was actually what was seen in the twice daily arm. So we're seeing a massive improvement in the twice daily arm compared to historical controls. And we suspect that's to do partly with the PET staging, partly for limiting these adverse biochemical features up front, but also potentially for the improvement in radiotherapy technique with more conformal techniques and image guidance within this study. Progression-free survival and the other endpoints, again, no statistically significant difference between the two arms. Acute chemotherapy toxicity, the only difference was in rate of neutropenia. However, there wasn't a statistically significant difference in febrile neutropenia. No difference, statistically significant difference in the acute radiation toxicity, pneumonitis or esophagitis, and again, similar percentage normal tissue doses reached in the plans. Late toxicity, again, no significant difference in any of these toxicities between either arm. So in summary, with a median follow-up of 45 months, the 2-year survival was high at 56% in the twice daily arm and high in the once daily arm at 51%, with very good median survival in both arms. The treatment was more deliverable to the total dose in the twice daily arm. Toxicities were comparable, and we didn't see a difference in acute toxicity, which had previously been seen in the Teresi paper, and high-grade pneumonitis was rare in both arms. So in conclusion, this has really established that we have 2 standards of care potentially now for these patients, with survival higher than previously reported in both of these. So I think this really allows us to offer patients either treatment. We may err on the side of twice daily because there was a trend for improved survival. However, if it's difficult to deliver, or if patients don't want to hang around the department all day and come twice a day and would prefer daily for 6.5 weeks, we now have another standard of care at a higher dose than we have previously has been standard. So I think this will be practice changing, and it's good to see a CR UK funded study presented at ASCO. So this was, I'm only taking one slide from the discussant, and this is just really to highlight in the context of the other trials that have looked at concomitant chemoradiotherapy in small cell. This is now where we are with CONVERT, with the outcome of the once daily and twice daily arm, just highlighting the improved outcomes. So then just a couple of studies in the adjuvant setting, resected non-small cell lung cancer. First of all, a randomised phase 3 study was presented with the addition of low molecular weight heparin into adjuvant chemotherapy following resection. And there's a number of reasons why it's thought that it may reduce metastasis, and the hypothesis being that we can improve survival by adding it into chemotherapy. So this was a randomised phase 3 study, and you can see patients were randomised within 4 to 6 weeks of surgery and either had adjuvant chemotherapy with the addition of low molecular weight heparin or didn't. And this was 2 weeks at therapeutic dose and then 14 weeks at half therapeutic dose. The primary endpoint here was recurrence-free survival, and they also looked at whether there was a difference in survival between those with high SUV uptake on PET in the tumour or low SUV, and neither of these showed any statistically significant difference. So the trial was slow to accrue, so they did recalculate the sample size partway through, but it still should have provided 80% power to compare recurrence-free survival. There wasn't a significant difference in bleeding events, but the addition of the low molecular weight heparin did not improve survival, and the SUV max did not predict for recurrence-free survival either in resectable non-small cell lung cancer. The other adjuvant study I just wanted to touch on, this was a post-hoc analysis of a previously reported study. So the background to this trial, adjuvant chemotherapy we know adds approximately 5% benefit for certain patients with resected early stage non-small cell lung cancer. The previously reported study on looked at whether addition of bevacizumab added anything. They've then pulled both of those arms to look at the different platinum doublets to see if there was any difference that they could eke out between any of these. So this was the trial, the cisplatin doublet. So you've got vinorelbine, docetaxel, gemcitabine, and then pemetrexed for the non-squames. 4 cycles, randomised to 4 cycles, and over 1,500 patients. So disease-free survival in the different arms, median follow-up is here, and disease-free survival in the non-squamous, no significant difference, and then in the squamous, again, no significant difference. Similar is seen in the overall survival. The toxicity, although there were some differences, these are all kind of fairly typical of the different agents, so I don't think there was any surprise there, and the pemetrexed being associated with lower toxicity overall. So the conclusion of this study is there was no difference in survival or disease-free survival depending on which platinum doublet you pick. Right, on to protons. Okay, so the phase 2 randomised controlled trial was reported comparing photon IMRT to passive scatter photons. So the hypothesis is, for anyone who's not a clinical oncologist in the audience, the reason that protons are so exciting is because of how they deposit the dose. So a standard photon, by the time you've reached your maximum dose, there's this long tail of fall off within normal tissues, giving sort of collateral damage potentially. Whereas the proton beam profile is, by the time it delivers its peak dose, this pink line here, it then has almost zero fall off. So you don't have extra fall off within tissue. And if you manipulate this proton beam, you can get what's called a spread out Bragg peak. And if your tumour is sat here, you get build up towards the tumour, maximum dose here over your tumour, and then pretty much no fall off. So this is why we all think it's going to potentially improve normal tissue toxicity, allow us to give higher dose. So the question asked in this study is whether we can reduce radiation pneumonitis and potentially reduce dose to the heart, and whether this will improve outcomes. So the consort diagram and the inclusion criteria, fairly standard inclusion criteria in this trial. The consort diagram is interesting. So of those patients that were randomised, if you look at the figures, actually only 82% ended up getting the randomised treatment. And this is for a number of reasons, but the one that was highlighted particularly is that the insurance company didn't always pay for example, the protons, and also patient choice. So randomised to RMRT, we've got a few patients here who just said, well, I'd quite like protons anyway. So the analysis here was not intention to treat, it was actually whichever treatment was delivered. Firstly, patient characteristics. So no difference in sort of patient characteristics. In radiotherapy treatment, there was no statistical significant difference between the volume of the disease treated. However, more patients treated with protons achieved a higher dose, the total dose of 74 Gray, than those were seen in the IMRT arm with photons. Overall, similar mean dose to the lungs, relatively similar mean dose to the esophagus, however reduced heart dose as we would expect, seen on the proton plans. So outcomes. Pneumonitis rates between the two were similar, and local failure rates between the two arms were similar. Now these two were combined in the primary endpoint. The primary endpoint was determined as treatment failure, either because of pneumonitis or because of local failure. Overall survival, no statistically significant difference between them. What was significant in the multivariate analysis of survival was age, radiotherapy dose, and overall tumour volume, which we would expect. And this just highlights the fact, because 18% of randomisational patients were excluded, this was not intention to treat analysis. This here, a median time of 4.3 months, it's not significant, but we are seeing quite a high level here of pneumonitis potentially in the proton arms, which is slightly concerning. The discussant, this was a very interesting discussion after this study was presented. We are seeing local failure at 12 months was lower than in the historical control, and they've compared it to the RTOG 0617 study here. However, the pneumonitis rate is higher than expected in the proton arm. And the overall survival of the IMRT arm is essentially the same as 0617, confirming that it remains the benchmark IMRT with photons. And this is just to compare it here. The median survival in months with photons, you've got the standard arm of RTOG at 28, and in this study here at 29 months. So the conclusion of this study really was, we're not really sure what this means. It could be that there really is no difference, despite the differing treatments, no difference between using photons and protons. However, there's another hypothesis that we are actually comparing very early implementation of protons to a very mature way of delivering photons. So particularly when it comes to image guidance and how we plan and deliver the radiotherapy, our photon IMRT is very sophisticated, and I'm not sure that we're there with our maximum ability to plan and deliver protons yet. We're concerned about marginal failure, and it has clearly been a steep learning curve with these new machines. So I think it's still very interesting. I think we need more data. And just to highlight this, the discussant looked at just the patients who were treated with protons and compared the initial cohort, when they were just learning how to use them, with the later cohort. And there's a big difference in V20 here and in the ability to achieve higher dose. So you can just see over the time they are being able to better plan the treatment, and what we haven't really seen yet is their better ability to deliver with image guidance yet. So I think there's more room for improvement with proton treatment going forward. And then just wanted to highlight that also in the States, there is the ongoing RTOG 1308 trial, which is in a phase 3 setting, randomising patients. So will give us more data over time. Interestingly here, they are randomising patients after there's been a funding decision, which will help prevent that fallout, but just coming back to what Richard was saying, could introduce significant delay to getting on treatment, because it can take a number of weeks to get a funding decision out of these companies in the States. And then lastly, I just wanted to touch on synchronous oligometastatic disease. So what we're really talking about in the synchronous setting is a small number of metastases at the same time as your primary is diagnosed, as opposed to the other terms in the literature, metachronous, which is where you've got a treated primary and you've got just limited number of metastases appearing at a time period, usually about 6 months or more after primary treatment, as opposed to oligoprogressive, which is where you're on a systemic therapy but only have a limited number of lesions progressing. So the trial design, this is MD Anderson study that enrolled patients having first-line systemic treatment, either to, so following chemotherapy, if they didn't progress, had no progressive disease after systemic treatment, either going on to physician choice of maintenance or surveillance, or adding in local therapy for 1 to 3 metastases, followed by either maintenance or surveillance. And this could be with surgery or radiotherapy, usually stereotactic radiotherapy. Interestingly, and I'll come on to why it's different in the UK study, they counted the number of METs after chemo. So not before chemo, after chemotherapy, it was 1 to 3 METs. So in theory, some could have disappeared. And the primary endpoint was progression-free survival. This trial was stopped early after the Data Monitoring Committee looked at it in January because of the observed difference between the two arms, with improved progression-free survival apparent in with the addition of local therapy. So they stated there was no statistically significant difference in a number of patient characteristics, although this one of histology came up quite a lot in the questions, and I think it'd be very interesting to see the full data on this. There was some discussion about maybe the adeno versus squame wasn't balanced, and I think here they sort of hinted it was more just balancing out the mutation positives against the others. So I think this is still to be further highlighted. So it ended up with it being stopped early, being relatively small numbers. However, this was the progression-free survival curves they showed, with the addition of local therapy giving us 11.9 months versus 3.9 months progression-free survival with the addition of local therapy. The other things that were significant are the number of metastases, again, after systemic therapy, and also, as we would imagine, progression-free survival distance based on whether they were mutation positive or not. Toxicity, there was quite a degree of crossover in the two arms after randomisation. However, they did comment didn't seem to be any real difference in toxicity between the two arms. The two exploratory analyses they commented on, they also suggest that there may be, so time to new site failure may be longer in those that receive the local therapy. And they also just had a statement here saying that even if they removed the mutation positive patients, the PFS benefit still remained. So they concluded that patients with oligometastasis who didn't progress after first-line systemic therapy, local therapy was associated with improved progression-free survival. And then the exploratory analysis I've just mentioned. Overall survival data is not yet mature. However, with the degree of crossover, I'm not sure if we'll necessarily see it, even if it does exist in this small study. Limitations, small size, feasibility is demonstrated, which I think is good. And then, so I just wanted to highlight the UK study. Again, CR UK funded. This is a similar concept, and this is funded and due to open a number of centres any day now. So here, similar, we've got primary non-small cell lung cancer, 1 to 3 metastases counted before chemotherapy. So right when you're diagnosed, 2 cycles of chemotherapy, and then you're randomised, if you don't progress, to either a further 2 cycles of chemotherapy and radical treatment to the primary with stereotactic radiotherapy to the sites of metastases, or to a further 2 cycles of chemotherapy with potential for maintenance as well. There's a feasibility sub-study to do with recruitment, and there's also an interesting toxicity sub-study based on the fact we might be giving radical radiotherapy to our primary with close by stereo to metastasis, which will also be very interesting. So take-home messages, I think the most exciting is the CONVERT study, localised small cell lung cancer. We now have 2 established chemoradiotherapy options available to us. In the data I presented just from those 2 trials, there's no change to adjuvant therapy options on the basis of that data. And I think in locally advanced non-small cell lung cancers, protons certainly still remain interesting, and I'm hoping that we will be part of that when we get our 2 proton machines at UCL and the Christie in the coming months or years. And again, in synchronous oligometastatic disease, I think there's more data to be teased out, although it is a small study, and I think this bodes well for hopefully recruitment to the SARAN trial going forward. Thank you very much.
Fiona, thanks very much for that excellent presentation and, of course, for keeping to time. Excellent. So lots to chew on there, because some great data, potentially practice changing. I've got loads of questions, but I'm going to open the questioning to the floor. If there are any burning questions, put your hand up and a microphone will come to you. Otherwise, I'm going to kick off and ask Fiona, so what should our radiation standard of care be now for limited stage small cell lung cancer? What should we be doing? What's your recommendation?
My recommendation is twice daily, if you've got the resources to do it, if patients are fit, and if patients are happy to stay for twice daily treatment. I wouldn't push them to do that if they didn't want to, because I think we have another standard of care. I guess the question for me comes in our routine practice, do we screen for those biochemical factors? Do we PET stage as much as is in the trial? I think we should push towards PET staging now, and we should start documenting, just keeping an eye on those biochemical factors. Yeah.
And is twice daily radiotherapy actually already available in the UK? Is it really implemented? Is it a standard of care that already exists? And how far will we have to go to actually make these practice changes in our radiation departments if that's what you as radiation oncology leaders suggest that we should be doing?
I don't actually know how many centres routinely offer. I think the majority probably do. Certainly our centre was sort of limited in numbers, but then we have so few small cells it doesn't tend to be too much of a problem. Interesting, much like when the REST data came out in the extensive stage, a survey has been done looking at practice before and after the results of the study came out, and I know that certainly Corinne's got plans to do exactly the same. So I think it'd be very interesting to document in that survey how practice changing this study has been. And certainly if you're in a centre that doesn't currently have the ability to do it, this should drive forward your service development.
Susan, microphone to the front, please, and a question there.
First, just a comment to say we also give BD radiotherapy as,
So you've
as
implemented
standard.
it.
We did it when we went into convert. We made
Yeah.
the BD our standard treatment. Then my question is, going forward from here, the BD dose of radiotherapy is actually really low. It always feels so low, given just 45 Gray. So with the hint that maybe because of the delivery time being shorter, that there's a trend to improve survival, the question that comes into my head is whether we can just increase the dose of the BD radiotherapy as a future aim.
Potentially, and we've seen the toxicity is not what we all kind of feared it might be. So yeah, potentially more dose. So I think that in so there's the ongoing American study that's taking it's increasing the dose of the OD arm, isn't it, to 70, not the BD arm. So we won't get that from the American data. But yeah, absolutely, it seems to be well tolerated, and maybe that's something we could look at. I think PET staging is interesting as well, because we don't know how much PET staging is added to this, and certainly I know that it's not allowed in Wales, for example. It's banned. So is that something we should start looking at? It's now routine in non-small cell.
Routinely in small cell as well.
Yeah, but there are pockets of the UK that can't do it.
It's not commissioned for small cell.
So there's a question about commissioning of PET and small cell, which seems to be patchily implemented in the UK. There's a question at the back. Has that been answered already? That's already been answered. Okay, question here.
Thank you. I think you have to be quite concerned about those last two trials that you showed. The one photons against protons, where they did a randomized trial and then didn't do an intention to treat. I mean, you introduce all sorts of biases by doing that. I'm really surprised that they allowed that. And also, with the first line plus or minus the local therapy, I mean, very small numbers of patients. And the fact that they stopped the trial that early is really quite concerning, I think. So I think you shouldn't draw too many conclusions by either of those studies.
No, I think they're certainly thought-provoking, and there's bigger studies in the phase 3 setting that will provide more data in both of those areas. The one I didn't mention, actually, there was another proton one, which was a retrospective, just kind of population-based take-all with IMRT, take-all with protons, that showed a survival advantage, but actually, you know, all sorts of confounding factors like, well, they've all got private insurance, they're probably from a different socioeconomic group, so to draw any sort of overall survival conclusion, which they did, which I think, you know, I didn't even put those ones up, but I completely agree. I think there's a lot more to learn about protons before we're going to see the benefits. And in the oligometastatic setting, I think it's very interesting, but we clearly need bigger studies.
Jesme, at the front, question.
So, Fiona, there's been an awful lot of hype out there about protons, and so I guess there's disappointment, taking into account the fact that there are perhaps issues with the study that you presented. Where do we kind of go with the hype now? Are we still hyped about protons generally?
We're hyped about protons. I think we're on a back foot a little bit in lung, because I think there's more to learn in lung because of how it deposits around pockets of air and the very real risk of geographical miss. So when you've got such a steep fall off, you can actually very accurately miss as much as you can very accurately target. And without strong motion management, we're going to struggle in lung compared to something that doesn't move, or compared to something that doesn't have big pockets of air like in lungs. So I think we've got a long way to go in lung, but I don't think I think we need to investigate it, and it still has promise. We just need to really get the other techniques, like the optimal algorithms, the optimal beam number, the optimal motion management, the optimal image guidance. There's so many other technical aspects that have fed into the photon arm traditionally that we haven't quite got there yet. So there's a lot more to learn. So I'm not too disappointed. I just think it's early days, and in some respects doing the study too early, you know, kind of running before you can walk type thing. We don't want to see it kind of damaged for the wrong reasons. But yeah.
Thank you. Another question.
Just to follow up on that, I guess, where do you think this whole field might be in, say, 3 years' time?
3 years' time?
Or maybe 5?
Well, we'll have 2 machines in the UK. Lung is certainly on the research agenda as far as I'm aware. I guess we'll be looking towards 1308, is it 1308? To see what data comes out there before we work out what questions we're going to ask here. I don't actually know the full capabilities of the machines that we're getting over here as far as image guidance and planning. So I think there's a lot we have to learn before we know what the next question is. But we've also got to remember we've got the 2 MR Linacs coming as well, which is a whole different new machine with other exciting opportunities. So protons potentially help solve the planning, this kind of making plans look pretty. MR Linacs tends to bring something different in a different machine to the whole delivery aspect. So if you say 15 years' time, I'd quite like to see a proton MR machine.
Why not? Any further questions? I'm going to ask you, Fiona. So, you know, in the US, we now have a randomised trial ongoing, protons versus photons. Do you think that that data that has been presented at ASCO will totally bomb out that trial? Will patients not be recruited in that trial because we've demonstrated in that study at ASCO that the potential, I mean, regardless, you know, take on board entirely the statistical comments here, but you know, there seem to be similar efficacy. There's a greater commercial bias in the US. Will that study ever recruit? Will we have any randomised data?
I think, well, the concern, I mean, clearly there's no cost analysis mentioned at all here, which is clearly a concern. And it's really, if that trial relies on insurance companies paying for it, I don't know what the insurance companies are going to make of that data. If they take that data and say, we're not going to fund it, the trial is going to struggle to recruit. And I think it's a very real problem, actually. That we were in, Corinne and I were in MD Anderson in December, and that process, my understanding is it can take weeks to get approval for protons. And as we were just saying, any week that goes by, can you justify waiting X weeks for a funding decision and delaying radical treatment? And will that just scupper the results anyway, just based on delay? I don't know. I think it's a very difficult question.
We need to sort out a design where it's balanced between the arms.
So there's a comment about sorting out the design between the arms to make sure that there is balance in the arms and ensuring that there's good statistical oversight, I guess, in that study. And I think that's a very valid and very fair point. Can I just ask one further comment in the absence of any further questions from the floor, just about Convert, you know, which is a great success for UK PLC and our research community, and I, you know, really think that certainly the investigator team and all folk that have put in patients to the study should be applauded for delivering this very hard randomised phase 3 study. So in terms of what we should be doing now in our clinics as of tomorrow with our next limited stage small cell lung cancer patient, you said that once daily is okay, twice daily is okay. But you know, a lot of folk are still giving once daily radiotherapy, which seems to be okay. What about the dose of that once daily radiotherapy? So in Convert, we're using a relatively high once daily dose, 66 gray, I think. A lot of folk are using a much lower dose. Should those that are using once daily radiotherapy immediately switch to 66 gray? And if so, does it have implications to the delivery of that service?
I think we should be. I think anything less than the 66 we should move away from. Implications, increasing a small number of fractions in a small proportion of patients, I just don't think it's got massive service implications at all. But certainly we need to make sure the data's out there, and any centre still using less than that on an OD fashion should consider changing.
So the standard of care, your message is that 45 BD twice daily or 66 once daily for limited stage concurrent is now the standard of care,
yes,
as of Chicago?
Yes.
Great. Any further comments? Dr. Booton at the front, thank you. Microphone please before you launch. Very good.
It was really just about cost, essentially. So given that the results were fairly similar in Convert, yeah, is there any significant cost difference between BD and once daily radiotherapy?
So one's 30 fractions, one's 33 fractions.
So you wouldn't expect a major?
No, it's the same planning. It's the same image guide. So much the same. It's a difference of 3 fractions, so it shouldn't be huge cost implications.
In terms of the complexity of getting people onto treatment, again, just in view of that delay thing, there's no real difference between.
No,
starting.
but in both arms they had 1 cycle of chemotherapy first. So you've got a 3-week run-in to do the planning, so it shouldn't be a big problem.
Okay. Thanks.
I mean, just a comment, I think I would agree that the numbers are small. So you're looking at small cell lung cancer being 10% of all lung cancer, or just over 10%, and you're looking at 30% of that 10%. So the numbers are going to be small. The numbers have got limited stage disease. And I think, as Sanjay said, I would just endorse moving away from the old 40 gray and 15 fractions, which, certainly when I became a consultant was the standard of care. And I think if you go around the country, there will be pockets of people doing that, and the message has to go out to increase the dose by whatever means.
What do you think, just back up the clinical oncologists in the audience, what would you now use sequentially in patients where you're trying to shrink the disease? What dose do you use?
Well, we use BD when we can.
Sequentially?
No, I mean,
if you're trying to shrink the disease, or they're a little bit frail, so you end up thinking, well, give the chemo first and we do sequential radiotherapy. What dose should we change our dose there?
We still use accelerated 15 to 20. So Dr. Hatton in the back using 50 and 20. Is that correct? Yeah.
Okay.
So I think what this adds to is the wealth of experience UK has in delivering.
I think what this adds is to the wealth of experience UK has in delivering accelerated hyperfractionated radiotherapy. I think we are well positioned to continue giving BD fractionation. I think that will become the standard of care across the UK and maybe established across the rest of the world. And what we need to do is to apply non-small cell experience we have with dose escalation and design the next trials, really.
Great. Well, thank you very much, and thank you for your excellent presentation. Our next speaker is Dr. Tim Benepal. Dr. Benepal is very well known to many of you. He's a member of the BTOG steering committee. And Tim has been following the field and what's been happening in the US over the last few days. And I've invited Tim to come here and give us an update on where we are with systemic therapies. The world of systemic therapies in lung cancer has really changed quite markedly over the past 5 years. We've gone from the chemotherapy era to the molecular targeted era to the personalised era, and now we have the immunologic era. How are all these data sets being combined together? So Tim, I'm really looking forward to your presentation and an oversight as to how we should be treating our patients, both with non-small cell lung cancer and perhaps also with small cell lung cancer. And I hope you will say a bit about mesothelioma as well, and any new changes to say over the data that's been presented. So Tim, I'll hand over to you. Thank you.
Thank you very much, Sanjay, and thank you to the audience for inviting me here today. A small confession to make. I didn't go to Chicago. So I have, with a lot of help from someone called Susan Mayer, without whom I wouldn't have been able to put these slides together. I've also had access to the virtual meeting in a limited sense, so I apologise if I haven't gripped all of the fine details, and perhaps Sanjay, if I miss something, please let me know. I'm going to initially just talk about 2 of the presentations on mesothelioma, and this is the only point where I'm going to discuss immunotherapy in any shape or form. For those of you who treat melanoma, you're familiar with inhibition of the CTLA-4 axis with ipilimumab, which certainly has demonstrated that it's quite an exciting drug. And this is a presentation of a study called the DETERMINE study in mesothelioma. And it should be applauded that they can do a study recruiting 571 patients. And this was a second-line study. And the key point that was made in all of these presentations is that we do not have a standard of care for second-line treatment in mesothelioma, despite the fact that a lot of us actually treat people second-line anecdotally. And so it's an applaudable design. Unfortunately, it was a completely negative study and showed absolutely no difference compared to placebo against for the drug tremelimumab. And the progression-free survival equally was negative. The conclusion from this study was that there was no evidence to support the use of CTLA-4 inhibition on its own. However, they did identify that the approach of just taking drugs like this and giving it to an unselected population almost certainly is going to result in negative outcomes. And we've learned that lesson painfully over many years in the treatment of lung cancer. And there is further work going on in terms of future trials in combination with PD-L1 inhibition, etc. Now, talking of PD-L1 inhibition, this was another study. This is a Javelin study. Now, we drift in and out of phase 1 and phase 2, and I've only got one proper phase 3 to show you. And this is a multi-cohort phase 1 study looking at avelumab. I think I've said that right. One of, I think, the 5 main PD-L1 antibodies. And this has got 16 cohorts with a plan to recruit 1,600 patients. So a very big departure from the traditional phase 1 trial. But they presented the mesothelioma data. And of course, we're now very familiar with looking at these lovely spider plots and waterfall plots, which are many different ways of trying to show the same thing. The conclusion from this study, however, wasn't completely negative, but there was some activity in the response rate in a second-line setting of approximately 9 to 10%. And again, you can see from this waterfall plot that there is some evidence of activity. So the drugs are not completely dead. However, the concept for our patients that these drugs are suddenly going to revolutionize their treatment, we should treat with caution. They looked at PD-1, PD-L1 expression in this study, and it didn't seem to correlate. There were responders who had no PD-L1 expression and responders who did. And again, they looked at survival by PD-L1 expression, and they couldn't really correlate anything with that either. So that question in mesothelioma remains unanswered. These are some of the other ongoing studies in the future. In Australia, they're opening a study of durvalumab first line in combination with chemotherapy. There are some combination studies looking at Nivo or Nivo plus ipilimumab based on a preclinical rationale, and there are a variety of other ongoing approaches in the future. Now, Fiona's talked about small cell and the very important CONVERT study, and unfortunately small cell lung cancer remains, from a systemic treatment point of view, an enormous challenge. And it was pleasing to hear on one of the videos that I saw of a presentation that the American government have taken an initiative to try and really tackle these very difficult to treat diseases. Unfortunately, the road to the small cell treatment in terms of drugs has been littered with phase 2 studies demonstrating very encouraging activity that then, when translated into phase 3 studies, turn out to be completely negative. And without going into details, literally every combination of anything you could possibly imagine has been tried in small cell with actually no demonstrable benefit above standard chemo and radiotherapy. So they presented an oral presentation from a phase 1 study, which makes you wonder how desperate things are getting. But this is a novel approach, apparently, and this is an atypical inhibitory Notch ligand, which I'm sure is blatantly obvious to all of you what that is. But Notch is a signaling pathway, and the reason that this target is thought to be relevant is that it's expressed in 80% plus of neuroendocrine tumours and also small cell. And the presenter actually referred to this as a warhead. I'm not entirely sure why, but it's an antibody drug conjugate, and it targets the DLL3 receptor. And again, the rationale for such a study remains questionable. As with all of these things, with these kinds of treatments, toxicity is pretty high, and these are patients who have had first-line therapy and have relapsed. So this is a very difficult group to treat, who are not that well. However, the reason it was an oral presentation is they think they may have found, possibly, a rational target in small cell. And so this shows you the overall response, which is a little bit better than standard second-line therapy with, say, topotecan. But when they looked at patients who had 50% or more DLL3 expression, the response rate seemed to get much higher. And this is approximately 70-odd patients. And again, they provide a rationale to go forward with further phase studies. And then again, if you look at this waterfall plot, if you believe in waterfall plots, and I think to some extent we do, for a second or third line relapsed small cell study, there appears to be a signal of activity. How this will actually translate into the real world with the subsequent phase 2 and phase 3 studies, we'll have to wait and see. But it's applaudable that this research still goes on. And this is just showing the median survival for differential expression of DLL3. I repeat, this is a phase 1 study. Good old-fashioned chemo is not dead, and there are a couple of presentations to mention. One interesting one, this is again another antibody drug conjugate. My understanding of these drugs, I'm not familiar with them in lung cancer. These are quite potentially toxic drugs to take. And this is actually taking a very familiar drug in GI cancers, in colorectal cancer, particularly irinotecan, and the active metabolite SN38, and delivering it to a mixed collection of non-small cell patients, squamous and non-squamous, in a relapse setting. And again, they were very excited about the fact that they were able to achieve a 20 to 30% response rate with this approach. I would argue, however, whether intensifying chemotherapy delivery is actually going to be meaningful for us in this current landscape. I only put this up because I've never seen an OS and PFS curve put on the same curve in a study. I'm not quite sure why they did it, but again, it was something of curiosity. The French, who I've now come to understand have a love affair with bevacizumab, and approximately use it for a third of their patients first line, which is quite different from the approach we have in the UK. So this was the ultimate study, as the presenter said. Second line, docetaxel versus weekly Taxol plus bevacizumab. Now bevacizumab, for those of you who aren't familiar, raised its head in this country about 10 years ago, and due to financial toxicity was thrown in the bin, and we've never really looked at it again. But it's widely used and it keeps coming back, demonstrating that if you add it to chemotherapy, there is some kind of rationale for doing so. And again, in this study, they showed a very significant difference in response rate in a second line setting. Docetaxel does exactly what it says on the tin and has done that consistently for how many years now, a response rate of 5 to 7%, but with Taxol and bevacizumab, a response rate of 23%. Their progression-free survival was statistically different. Their overall survival wasn't, but their argument behind this was that in both of these arms, patients crossed over, and the same proportion of patients crossed over, approximately, I think, 30 to 40%. So they're suggesting that in the second line landscape, which has actually become the most interesting, we have yet another potential treatment option. Whether we could actually get access to any of these in this country is a different issue. I'll talk a little bit about ALK now. Well, I'll say a little bit. This was probably the most discussed area at the presentations at ASCO. I'm not sure if any of it is realistic for any of our patients on a day-to-day basis looking forward, but it's very interesting data. So this was the JLEC study, a phase 3 first-line study for ALK gene rearrangement positive patients, so treatment naive, and they were randomized to what we would probably consider our standard first-line treatment with crizotinib, even though we can't actually access it first line on the NHS, versus alectinib, which is a new generation, even fancier, even more clever drug. And looking really, asking the question is, are the newer drugs better, and should we be using them up front? And if you look at the waterfall plots, they don't tell you the entire story, but it certainly would appear that alectinib has a lot more patients this side of the line. And then if you look at PFS as their primary endpoint, PFS wasn't reached in the alectinib arm, therefore suggesting that this is a far superior drug, due to the fact that it has a different profile of inhibitory activity. And again, if you look at the forest plot, everything seems to more or less favour alectinib. The suggestion by the presenter, as I understand it, was that this should become the standard of care, but at $12,500 per 4 weeks. I'm not entirely sure if that is going to pan out. Not to mention the fact that there are other inhibitors out there, such as brigatinib. This is yet another new generation ALK inhibitor. And again, this was an earlier phase study, and it was looking at 2 different doses of brigatinib, 90 and 180 milligrams, to determine a difference in efficacy. And again, you can see that at both doses there appears to be very impressive activity. And this was a study in the relapsed setting. So this is not first line. This is patients who've previously been treated with crizotinib and also some of them with chemotherapy. So this again is showing activity in a relapse setting and quite encouraging activity. And again, progression-free survival, the suggestion was that this was better at the higher dose of brigatinib. And I've no idea how much it costs, but it's another drug out there for ALK-resistant patients. And then there was another discussion, and this, again, an even earlier phase study about lorlatinib, which is yet another third-generation inhibitor with a different spectrum activity, and again thought to overcome some of the resistant mechanisms that people developed to crizotinib. Now, my understanding is that to go full circle with this story, patients on crizotinib who've then progressed and then gone on to second or third generation inhibitors and then possibly lorlatinib, who then progress on lorlatinib, there's been a case report, I think, of patients developing resensitivity to crizotinib as a result, so going entirely full circle and onto fourth-line therapy. So where we go with all of this, I have no idea, and how it's affordable and which one of these is the best to use remains a mystery. In the UK, our hands are tied. We don't have first-line crizotinib approval, so I'm not sure at this point how any of these drugs are necessarily going to be available. I haven't, of course, mentioned ceritinib, which is obviously another one which is licensed. And this is just showing you the activity in this resistant group of patients with lorlatinib. And again, you're seeing another drug here showing activity in ALK-resistant patients. ROS1 is also targeted by these drugs, and again, ROS1 patients are rare. We very infrequently see them, but they have exquisite sensitivity to these drugs. So finally, I'm just going to mention EGFR. Now, again, you're all familiar with the story. As you know, that we've, over the years, now have access to 3 first-line EGFR targeted TKIs, gefitinib, erlotinib, and afatinib. And we could have a long debate about which of those is the best to use, but they're probably very similar. But there's a new generation of drugs that have been floating around for some time. And the big discussion at ASCO this year was about testing and whether testing tissue versus liquid biopsy and the feasibility of that. And they actually used data from the rosiletinib studies, the TIGER-X study program. Rosiletinib is a drug developed by a company called Clovis, and for reasons that are not absolutely clear, the drug has stopped in clinical development, but there is a lot of data available. So one of the presentations really was about how easy is it to test for the presence of EGFR mutations, and in particular the resistance mutations, the commonest of which is T790M in the serum or the plasma. And they talked about an assay whereby PCR is done in the blood and flow cytometry is then used to detect mutations. And again, apologies, this looks like a complicated Venn diagram, but this is a subset of patients, all T790M positive. And what they're saying here is that this 104 are positive in all 3 modalities. 5 patients urine only, 4 patients plasma only, 19 urine and plasma, etc., etc. And with an 80% sensitivity for the urine and the plasma testing. So assuming that patients are going to have to be re-biopsied before you consider giving them any further TKI therapy is not necessarily the case. And from a patient perspective, to be able to do these tests in the blood is very encouraging. Last year they presented all of the osimertinib efficacy data, but this year they focus very much on CNS disease. And we're familiar with the fact that these patients frequently get brain metastases, and it's not been entirely clear how we treat them. There's been a debate about whether they should have radiotherapy. There's been a debate about whether our first-line TKIs actually penetrate into the brain, and the truth of the matter is their penetration is relatively low. But some of the new generation inhibitors do. And this is two sort of early phase 1-2 studies. One looking at osimertinib, which is the AstraZeneca compound, at a higher than normal dose, and specifically looking at patients with brain metastases. And the other is another AstraZeneca compound, 3759, which is specifically in a preclinical development process been demonstrated to have high CNS penetration. And they use an index to measure CNS penetration called KPOO, no pun intended, it's PUU, and they measure the drug levels in the CNS versus the plasma. And if that ratio is 1, it means you've got similar levels, which means you've got high penetration. And certainly for this drug it's 1, for this drug it's about 0.4, and for gefitinib and alotinib it's somewhere in the region of 0.02, just to give you an understanding. And the bottom line from this study is that, and they look specifically at their brain metastases, and again, it's low numbers of patients, but to recruit people with brain mets and then measure the outcome of that brain disease is quite an achievement. And with 3759, you're seeing some very encouraging responses. And this is with osimertinib, and again, this is showing actually clinical benefit. So this is patients who have either got no symptoms, but those who did have symptoms, they're actually measuring the improvement. And I haven't shown all the slides here because I didn't want to saturate people with lots of pictures, but again, they also measured CSF levels of disease and demonstrated in individual patients that with these drugs, the CSF, in some of these patients, the disease became undetectable. And again, that was the main focus. Oh gosh, I've been very quick.
So Tim, thanks for that excellent overview. I mean, there's lots going on in the field of advanced lung cancer and also mesothelioma. I'll open the presentation to the floor for questions, but I'll start off whilst you're warming up your grey matter by asking Tim, with meso and immunotherapy, and there's been a huge amount of hype about the role of immunotherapy in meso. I mean, do you think that the data that you presented with avelumab, 10% responses, is that realistic for what we're seeing with PD-1 inhibition in meso itself, or do you think that's a drug-specific effect? Because the Pembro and Nivo studies have shown 20-25% responses so far.
So that is a very good question. There are, to my knowledge, there's 5 drugs in development, 2 PD-1, which is obviously Nivo and Pembro, and the others are PD-L1. And we're only coming to a sort of consensus from early phase studies as what their activity is. And I'm still not sure we have a clear idea of who our target population is. I genuinely don't know the difference between the molecular structures of avelumab versus the others. I think this is something we're going to end up learning after the event. There was a lot of discussion in those presentations about looking at immune cell rich populations within tumours, and that's a predictive factor. Also, epitopes on the cancer cells may have some role to play. Why is it that tremelimumab is such a negative drug, where ipilimumab is? What's the difference between those two? And there's discussions about the combination of PD-1 and CTLA-4, one potentiates the other. There's so many questions being asked, it is literally impossible to see the wood for the trees at the moment. So the short answer is, I don't know. What I do know is that patients, certainly my patients, have seemed to have got it in their head that somehow these drugs are, forget about doing a trial, they are the thing to get. And I don't know where that's come from, not in meso, anyway, certainly in the others, perhaps.
So the title of the discussant session in meso was called Mesothelioma Reality Check.
Correct.
And I guess that's your interpretation of the data is actually we need to we need to take a fresh look at this data without the rose-tinted glasses and really reevaluate where we're going with development of these agents. The Determine study was the relapse mesothelioma trial that you talked about, which randomized patients between placebo and tremelimumab, CTLA-4 agent, and it was one of the largest international phase 3 trials with mesothelioma, and the UK was one of the lead recruiting sites for that. So it's a great demonstration that the UK can lead in mesothelioma studies. Do you have any thoughts on why that study might have been so negative? Do you think it's really the drug is not that active, or do you think it's the toxicities of the CTLA-4 compounds, which can have quite a lot of toxicities, which negate the efficacy that we're seeing?
So the assumption with the use of these agents is that you've got tumour cells sitting there actively inhibiting the immune process and then therefore allowing their existence. And certainly that is well documented, but in mesothelioma we're also very familiar with the fact particularly epithelioid patients can sit there quite happily for years with disease that we've diagnosed, and it's very small volume and it does nothing. Now when you've actually got very little immune suppression going on, are these drugs actually going to make any difference at all? Yeah. And I think that is quite a key point. And where is the point that you want to target these drugs in terms of timing? Equally, it's certainly true to say that any patient who is progressing rapidly, this approach is not the best way to try and stop that disease growing, because you're trying to introduce a longer term change. So I just don't think we've got all the answers yet, but certainly I think they did discuss the fact that a lot of these patients probably don't have too much immune suppression going on.
Yeah. Questions for the floor? Question from the front and then the second to back row.
Thanks. Just going on about the liquid biopsy testing. Is it your impression from the meeting that it is coming into clinical practice already?
It's not currently available to me in my immediate environment. It is my impression that it's coming just because of, I think logistically, putting somebody through a biopsy and what that takes in terms of time and resources versus sending off a blood sample ultimately has to make sense. But
do you think it's proved itself in terms of sensitivity? I guess that's my question. Do clinicians feel it's ready to go?
80 to 85% in this context, that's pretty good, I think. It might not be in other applications. Having currently been in the position of having to rebiopsy people to get them onto osimertinib if they've got a T790M mutation, you have to really plan the process. You have to pick the time, see right they're progressing, get them on the MDT, re-image them, arrange the biopsy, get it sent off, get the result back, and that takes quite a lot of effort. So I hope so, certainly.
Thank you.
Question at the back from Frank.
My question is easy as well, so that's very nicely answered.
So question about ctDNA.
ctDNA.
Okay. So comment from Dr. Booton at the front, who was making all sorts of faces about the role of ctDNA. Is ctDNA really established, do you think, Richard, or do you think there's some still controversy about it?
Let me ask you a question, really, because sadly I've been qualified too long. So 30 years ago, it was always said it was very hard to get hold of lung cancer tissue, and that's why we could never make any progress at all in lung cancer. And today, it has never been easier, more tolerable, or repeatable to get tissue out of lung cancer patients. So what's the obsession with not? And when you factor into the fact that, if you listen to Professor Swanton talk about tumour heterogeneity and how important it is to understand the molecular landscape of different regions of tumours, why are we averse to taking biopsy samples? You've already just mentioned second-line small cell. Perhaps we would be further ahead if we had more of an appetite to re-biopsy disease and understand the biology better. So
one simple answer to that, from my perspective, and you give the option of taking a blood sample, sticking one of your fancy ultrasounds down their throat, or sticking a needle into their chest, they often will go for the blood sample. And the patient, if it's just as good, would prefer that.
But that's because you called it a liquid biopsy, and it isn't. If I tell a patient you can have a biopsy, it'll give you the same information from a blood test versus what we do, then I agree. But you're telling them lies.
Well, I don't use that terminology, but It depends on what you're not going to, I agree, you're not making a new diagnosis of small cell on circulating tumour. You're asking a specific question about the presence or absence of a mutation.
Just to go back to your presentation, so the DLL3
Yeah.
in small cell, was that expression based on baseline biopsy or on relapse?
I believe so, yeah. But I mean, as with all small cell studies, very loose rationale. So suddenly this appears out of nowhere as expressed in 80% of neuroendocrine tumours. It's not predictive for outcome either.
But it just intrigues me because obviously small cell is one of the easiest things to rebiopsy with most techniques. So
comment from Frank. I know you do a lot of ctDNA work.
Back to the ctDNA. I think the data from multiple studies suggests that the concordance is excellent between tissue and the circulating tumour DNA. So I guess that's one point for the blood tests. The patient assessment of what they would rather have. Most patients, I'd agree with Tim, would much prefer a blood test. And the third point is you may bias your sampling by selecting one site for your biopsy. We've all heard a lot about tumour heterogeneity in recent years, and there's a strong argument that by biopsying the blood, inverted commas, you may be reflecting the totality of disease as well as the dominant clones. I think there's sufficient evidence to suggest that is the case.
So I'll draw this debate to a close by summarising that there's obviously some question about the utility of ctDNA analysis for EGFR. I mean, it seems to be very attractive. The question is really, do we need additional biopsy? And certainly for the T790M negative cohort on ctDNA, we certainly need to do that. And I think the bigger question is, what additional gains are we getting from the histology, which could be quite significant in terms of morphological analysis and other opportunities to perform an NGS on that specimen. And the meeting was replete with lots of molecular other data as well for other targets, which are often used on tissue-based biopsies. But I guess some folk would argue that circulating DNA NGS analysis is the next step forward, and I guess we'll hear more about that in our ASCO update from 2017. But is there any other further questions for Tim? I'll take a question at the front from Jesme.
Tim, last year, so ASCO 2015, the big news in the lung cancer business was immunotherapy. What, from your perspective, or was there the big news in drug therapy? What was it this year?
Well, it was much harder to get a clear message. There were no plenary sessions. Probably the most impressive data was about alectinib, but I mean, again, I'm not sure how much that's going to translate anytime soon into clinical practice. Definitely the message was that with these group of patients we now we but we categorise as being molecularly genetically driven in their cancers. It would appear that in ideal world scenarios that we'd probably never have to put chemotherapy in front of these patients again, because we've got this emerging machine chucking out molecules left, right and centre. And there's some very, very clever stuff being done, looking at defining resistance, targeting it and then redefining it next time round. But then this is in a small group of patients. So you're right, Jesme, I did not go through it all thinking, wow, there's an overwhelming message here. The immunotherapy side of it was certainly quieter, wasn't it?
And I guess you then come down to the big reality check, and that, well, for NICE at the moment, who regulate our therapies in NHS England, we've got, 15 open appraisals at the moment? How many of those are we going to get through? So I guess there's some big reality check for all of us that kind of very exciting, but it all comes down to
the
cost.
Elephant in the room. Again, how realistic is this going to be for our clinical practice? I cannot see, I mean, the way that some of the NICE modelling is done, even, I know because I've heard this from pharma companies, even when they go in with a drug for free, the model churns out that it's still way above the £30,000 limit. So I just can't see how any of these are going to get through. I mean, one or two slip through like nintedanib, but you're absolutely right. We have to restructure our thinking of how this is going to work.
Great, thank you very much. Tim, thank you for that excellent presentation. I think your comments, Tim, really feed to some of the policy discussions that will be had in the afternoon, and there's a really strong interplay between emerging data and policy, and I'm really looking forward to what the foundation here do in terms of influencing our policy for therapeutic and local treatments access over the next few years. So thanks very much, Tim. I'd just like to close by saying a few words, if I may. I think this has been an excellent session. We've put together a set of data which were presented only a handful of days ago and given some real expert critique to that data and how that may or may not impact into our daily clinical practice as of tomorrow. And if it isn't going to impact on our day-to-day clinical practice as of tomorrow, what should we be planning for to plan for the next set of changes as they're implemented? Certainly the aspects of therapeutic availability are a big issue in the United Kingdom, and of course this is a bigger piece occurring outside this room with the various partners in the field. So I'd just like to thank a few people that have made this event possible. So first of all, Jesme, for having the great idea and sense of presence to decide that this was a great idea. The steering committee of BTOG who supported this wholeheartedly. Dawn from the BTOG office who's helped assist to put this all together. Also, great thanks to Sue Mayer, who spent endless hours in Chicago getting to the data all together for our speakers. A definite huge thanks to our speakers who put a lot of time and effort into getting these presentations together, which can often be quite challenging when you've been away from work for a period of time and have got all of that to catch up with as well. And also our audience, both here physically and online, for taking the time to watch and ask questions. I'm sure our speakers here were very happy to be contacted personally, both today and by email online, if there are any questions to be asked arising from this presentation. And with that, I'd like to bring this session to a close, and thank you very much for your attention. Thank you.